Gait is a fundamental motor function, seamlessly integrating the brain, spinal cord, peripheral nerves, and musculoskeletal system. Disruptions in any of these systems can result in pathological gait patterns, often offering valuable diagnostic clues in neurology. In this video, we will explore the neurophysiology of gait, systematically assess abnormal gait patterns, and discuss how different neurological disorders manifest in distinct walking abnormalities. By mastering gait analysis, clinicians can improve their ability to localize neurological lesions and refine their approach to neurological diagnostics. Walking is a rhythmic, highly coordinated movement controlled by complex neural circuits. The gait cycle consists of two main phases. Stance phase, 60%. The foot is in contact with the ground and supports body weight. Heel strike. The heel makes initial contact, controlled by the dorsiflexors and quadriceps. Loading response. Weight shifts forward, stabilized by hip extensors and plantar flexors. Mid-stance. The body moves over the supporting foot, requiring core balance and proprioception. Terminal stance. The heel lifts off, driven by gastrocnemius soleus contraction. Pre-swing. The foot pushes off, powered by toe flexors and plantar flexors. Swing phase, 40%. The foot is off the ground, moving forward. Initial swing. Hip flexors initiate forward movement. Mid-swing. The knee extends and dorsiflexors lift the foot to clear the ground. Terminal swing. The leg prepares for the next heel strike with controlled hamstring braking. Neural control of gait is distributed across multiple levels. Spinal cord, central pattern generators, CPGs, generates rhythmic stepping movements, even without brain input. Brainstem and reticulospinal pathways controls gait initiation and posture adjustment. Basal ganglia regulates movement smoothness. Dysfunction here causes shuffling in Parkinson's disease. Cerebellum ensures balance, precision, and adaptation to terrain. Lesions cause ataxic, unsteady gait. Sensory systems, proprioception, vision, and vestibular input provide real-time corrections for stable walking. Disruptions at any level of this system lead to pathological gait patterns, offering crucial diagnostic insights. Mastering gait cycle analysis enhances neurological localization and clinical decision-making. A thorough gait examination begins before the patient even takes a step. The goal is to assess posture, balance, stride, and coordination systematically. Here's how we do it. 1. Observation of stance and posture. Observe the patient's posture at rest. Is there a stooped posture suggestive of Parkinsonism? Is there a widened base often seen in cerebellar dysfunction? Watch how the patient rises from a chair. Difficulty standing up without using the arms suggests proximal muscle weakness seen in myopathies or Parkinson's disease. 2. Initiation of gait. Pay attention to how the patient starts walking. Hesitation or an inability to initiate movement, feet stuck to the floor, suggests gait apraxia or freezing of gait. 3. Stride length and arm swing. Is the step length normal, shortened, or irregular? Is there reduced or asymmetric arm swing? 4. Turning and maneuvering. Watch how the patient turns. A normal individual pivots smoothly, while a Parkinsonian patient may take multiple small steps en bloc turning. A patient with frontal gait disorder may appear uncertain or hesitate mid-turn. 5. Special tests. Tandem walking assesses balance and coordination, impaired in cerebellar ataxia. Heel and toe walking detects foot drop and plantar flexor weakness. Romberg test differentiates cerebellar ataxia, unsteady with eyes open, from sensory ataxia, worsens with eyes closed. Pull test evaluates postural reflexes in Parkinson's disease. By combining observational skills with neurological examination, we can systematically classify abnormal gaits and localize neurological dysfunction. In this segment, we will explore distinct abnormal gait patterns, how they manifest clinically, and their underlying neurophysiological causes. Recognizing these gait disturbances is essential for localizing neurological lesions and determining the underlying pathology. Let's examine the most common pathological gait patterns encountered in neurological practice. Hemiplegic gait is a hallmark of upper motor neuron (UMN) lesions, commonly caused by stroke, traumatic brain injury, or multiple sclerosis. It results from spasticity. Increased muscle tone causes the affected leg to extend and stiffen. Weakness of flexors. The hip and knee remain extended due to impaired voluntary control. Loss of reciprocal inhibition. The inability to coordinate opposing muscle groups leads to an awkward, inefficient gait pattern. Clinical features. The affected leg is stiff and circumducts, swings outward during swing phase to clear the ground. The foot is plantar flexed and inverted, causing it to scrape the floor. The ipsilateral arm is flexed, adducted, and does not swing. The lesion can be localized to contralateral motor cortex or internal capsule, commonly from stroke. Upper motor neuron damage disrupts the corticospinal tract, leading to spastic paralysis. Brisk reflexes, clonus, and a positive Babinski sign are present on the affected side. Unlike Parkinsonian gait, the stride length is normal on the unaffected side, but severely reduced on the hemiplegic side. Spastic diplegic gait is seen in bilateral upper motor neuron disorders, such as cerebral palsy, hereditary spastic paraplegia, and severe spinal cord myelopathy. It is caused by bilateral hypertonia of the lower limbs. Excessive tone prevents normal leg separation. Hip adductor spasticity. The thighs cross over, producing the classic scissoring movement. Extensor hyperactivity. The legs remain stiff and extended, limiting flexibility during walking. Stance phase is affected by a narrow base and instability, and swing phase is limited by adductor tightness, stiffness, leading to crossing of legs in this diplegic gait. Patients have difficulty clearing both feet, so they may take short steps and often walk on tiptoes due to equinus posturing of the feet. Knee flexion can be limited, causing the legs to circumduct slightly or scrape. The adductor spasticity causes the knees to cross or rub together, hence the scissoring appearance. Turning and maneuvering are challenging. These patients can fall if they catch a foot. Hypertonia and hyperreflexia in leg extensors and adductors from bilateral corticospinal tract damage, poor selective motor control in legs. Localization, bilateral periventricular lesions as in periventricular leukomalacia of cerebral palsy, or spinal cord lesions affecting both lateral columns, as in parasagittal meningioma or high thoracic myelopathy. In cerebral palsy, perinatal hypoxia causes this pattern. In adults, severe cervical stenosis or myelopathy can produce a spastic paraparesis gait resembling a scissor gait. Parkinsonian gait is a hypokinetic gait caused by dysfunction of the dopaminergic pathways in the basal ganglia. The patient has a stooped, forward-flexed posture with reduced arm swing. Steps are shuffling, short stride length, and typically rapid, giving the appearance of the patient trying to catch up with their center of gravity, festination. There is difficulty initiating walking, start hesitation, and upon initiation, the steps may unintentionally quicken. Turning and block, whole body turns stiffly as one unit, and difficulty stopping are common. In advanced cases, freezing of gait can occur, where the feet appear stuck, especially at doorways or turns. In gait cycle, both the stride length in stance and foot lift in swing are decreased. Heel strike is often absent, and feet may barely clear the floor. There is prolonged double support and difficulty with initiation, a freezing in pre-swing phase. Due to dopaminergic loss in the basal ganglia, there is bradykinesia, an inability to generate adequate amplitude of movement. Postural reflexes are impaired, contributing to instability. Basal ganglia output excessively inhibits brainstem locomotor regions, requiring extra effort to start gait. This can be localized to substantia nigra pars compacta degeneration, idiopathic Parkinson's disease, or other nigrostriatal pathway lesions. This gait can also be seen in Parkinson plus syndromes, e.g. progressive supranuclear palsy, and diffuse subcortical small vessel disease in the elderly, giving a lower body Parkinsonian gait. Cerebellar gait ataxia occurs when the cerebellum fails to coordinate movement, leading to an unsteady, lurching walk. Clinical features are wide-based stance for compensation, irregular foot placement with steps varying in size, veering toward one side, often toward the side of the lesion, difficulty with tandem walking, heel-to-toe walking. In the gait cycle, all phases are poorly coordinated. The initiation may be hesitant, foot trajectory and swing is misjudged, and landing can be abrupt or uneven. Patients might exhibit a longer double support phase for stability. In this video, can see the patient's gait is wide-based and unsteady, with erratic foot placement. Patients have difficulty walking in a straight line or performing tandem gait, heel to toe. They may sway or stagger toward the side of a cerebellar lesion. Steps are irregular in timing and distance, dysrhythmic and dysmetric. There is often accompanying truncal titubation, body swaying, and inability to maintain balance, requiring broad stance. Cerebellar vermis lesions produce a midline ataxic gait. Hemisphere lesions can also affect gait, but often with limb ataxia. Spinocerebellar pathway lesions or severe sensory ataxia can mimic cerebellar gait, but pure cerebellar ataxic gait is due to cerebellar dysfunction itself. Causes include stroke, cerebellar degeneration, multiple sclerosis, cerebellar plaques, tumor, or intoxication, e.g. acute alcohol effect on cerebellum. Sensory ataxia gait arises from loss of proprioception, leading to exaggerated compensatory movements. Clinical features: high-stepping gait, the patient lifts their legs excessively. Foot slap, the foot forcefully strikes the ground. Worsens in the dark, due to loss of proprioceptive input. Positive Romberg test, the patient sways or falls when eyes are closed. In gait cycle, the stance phase shows an insecure, stamping foot placement, particularly at initial contact, which is often a heel strike followed by a slap as the foot drops. Swing phase may be exaggerated, with high stepping to ensure clearance due to lack of position sense. Balance is impaired, especially during single limb support, so patients often hesitate or increase double support time. As a result from loss of proprioceptive input in the legs, the patients walk with a wide base and foot slapping. They lift the legs high and bring them down forcefully, stomping the ground to generate sensory feedback. They appear to watch their feet intently while walking. In darkness or with eyes closed, the instability worsens dramatically, positive Romberg sign, and they may not know where their legs are in space. Lesion mostly localized to dorsal column medial lemniscus, with loss of proprioceptive afferents, means the patient cannot sense joint position. The compensatory mechanism is visual guidance and increased impact to stimulate any remaining sensors. Without visual input, gait decompensates. There is no primary weakness. Rather, it's a failure of sensory feedback needed for coordination. This is the steppage gait, also known as the neuropathic gait. It's a classic sign of foot drop, where weakness in ankle dorsiflexion causes the toes to point downward during swing. The underlying cause? A dysfunction in the peripheral nervous system. In the gait cycle, the most obvious change is during the swing phase, where the high hip and knee flexion prevents the toes from catching the ground. In the stance phase, you may hear or see the foot slap as the dorsiflexors fail to eccentrically control plantar flexion after heel contact. To compensate for the dragging foot, the patient lifts the knee and hip excessively, creating a high-stepping motion, almost like climbing invisible stairs. At heel strike, instead of a smooth landing, the foot often slaps down due to poor dorsiflexion control, a feature known as the foot slap. The root problem lies in weak or paralyzed dorsiflexor muscles, especially the tibialis anterior. This occurs from disruption of the common peroneal nerve or its upstream supply, such as the L5 nerve root. The tone is flaccid, unlike the spasticity seen in upper motor neuron lesions. Common causes include peroneal nerve palsy at the fibular head, L5 radiculopathy, or peripheral neuropathy from diabetes. Bilateral steppage gait may be seen in Charcot-Marie tooth disease or motor neuron diseases. The hallmark? A lower motor neuron lesion, most often peripheral. This is the waddling gait, also known as the myopathic gait. It results from proximal muscle weakness, especially involving the hip girdle, leading to poor pelvic stabilization during walking. Patients show a distinctive side-to-side trunk sway with exaggerated hip elevation, resembling a duck-like waddle. With each step, the pelvis drops on the side of the lifted leg, a classic positive Trendelenburg sign. To compensate, the patient shifts their torso toward the stance leg to avoid falling. During the stance phase, the weakened hip abductors can't stabilize the pelvis, causing it to tilt downward. To maintain balance, the patient leans over the stance leg, creating a broad, waddling appearance. The step length may remain near normal, but the gait is often slow and energy-consuming. The key deficit is in the gluteus medius and minimus, the main hip stabilizers. Weakness here causes pelvic drop and imbalance. In disorders like Duchenne muscular dystrophy, compensatory lumbar lordosis often develops, helping shift the center of mass backward due to hip extensor weakness. The pathology localizes to proximal pelvic muscles, typically in myopathies like muscular dystrophies or inflammatory myositis. It may also occur in neuromuscular junction disorders or structural conditions like bilateral hip dislocation. The hallmark example is seen in Duchenne muscular dystrophy in children. This is the frontal gait disorder, also known as gait apraxia or gait ignition failure. Patients often describe it as though their feet are glued to the floor. Despite normal leg strength, they struggle to start walking, a hallmark of this higher-level motor disorder. Once walking begins, the steps are short, shuffling, and broad-based with poor foot lift. The arms may swing normally, unlike in classic Parkinsonism, but turning and navigating obstacles are difficult. Patients may stop suddenly or freeze mid-walk, especially when distracted or asked to turn. The most striking deficit is in gait initiation. Patients hesitate, taking several attempts to start moving, a phenomenon sometimes called start hesitation. During gait, the swing phase is reduced with a shuffling pattern known as marche à petits pas. There's no festination, but frequent freezing and sudden stops are typical. This disorder reflects impaired motor planning, not weakness. The frontal lobes, particularly the supplementary motor area and its connections, fail to generate or transmit the command to initiate walking. In conditions like normal pressure hydrocephalus, periventricular white matter disease disrupts these pathways, disconnecting frontal signals from basal ganglia and brainstem locomotor centers. Localization is to the bilateral frontal lobes or subcortical white matter tracts. Common causes include normal pressure hydrocephalus, Binswanger's disease, or frontal lobe tumors. These are termed higher-level gait disorders, distinct from gait disorders due to weakness or cerebellar imbalance. Gait assessment is an invaluable neurological diagnostic tool. By understanding the neurophysiology of gait, recognizing distinct abnormal gait patterns, and employing a structured clinical approach, clinicians can localize neurological lesions with remarkable accuracy. For specialists in neurology and neurosurgery, proficiency in gait analysis enhances early diagnosis, targeted interventions, and fall prevention strategies, ultimately improving patient outcomes.